Welcome back to the Deep Dive. Today, we're taking on one of the most high-tech, high-stakes tools in the emergency room, on-call body MRI. For most of us, an MRI is something you schedule weeks out. But it's really shifting, isn't it? It's becoming this critical problem solver in the moment. So our mission for you, the learner, is to unpack that whole diagnostic roadmap. We want to get into the when, the why, and the how emergency teams deploy this scanner. And this isn't about routine stuff. This is about MRI as the final word, the tiebreaker when ultrasound or CT just can't give an answer. Or, and this is key, when they're totally contraindicated. We're looking for how they get that high-yield information fast when a patient's safety is on the line.
Right, and what's so fascinating is the strategic shift that's happening here. I mean, for years, MRI was too slow for the ER. But the hardware, the sequences, they've gotten so much faster, so now its core value is really about safety.
Safety in what way?
Well, two big things. First, it's free of ionizing radiation. It's non-negotiable for certain people, like pregnant women or very young patients. And second, we can often get what we need without injecting any contrast dye.
Which is critical for patients whose kidneys are compromised.
Exactly, where traditional CT contrast could do real harm. So that combination of speed and safety, that's why it's become so indispensable on call.
That makes perfect sense. Avoiding radiation contrast just opens up the options for so many more patients. But let's talk about the chaos of the ER for a second. Before a patient even gets into that scanner, there has to be this complex triage. What are the first hurdles?
Oh, the pre-scan checklist is intense. And it has to be because the environment is so urgent. It all starts with mandatory safety checks. I mean, we have to be absolutely sure there's no internal metallic hardware, certain pacemakers, foreign bodies.
Things that would be catastrophic in a giant magnet?
Exactly. If they have a high-risk implant, the study just stops right there. Full stop. But even after you clear that, you've got physiological hurdles. You have to assess, is this patient stable? Are they going to crash in the middle of the scan? And then there's breath hold capacity. These patients are often in terrible pain. They might not be able to lie still or follow commands.
So the radiologist has to be ready to pull the plug at any time.
At any time. And that means you have to prioritize. You focus really intensely on getting the most important sequences first.
Just to guarantee you have something to work with, even if you can't finish the whole thing.
That's the goal. Minimum diagnostic quality, even with an incomplete study. It's a high-stakes calculation.
It sounds like a constant trade-off. You get the benefit of no radiation,
Yeah.
but the cost is, well, it's less time and maybe a less than perfect scan.
That's precisely it. But sometimes there's just no other choice. Take a pregnant patient with acute abdominal pain. Ultrasound can be really limited, especially late in the pregnancy when the uterus is pushing everything around. In that case, MRI becomes the go-to. It's the best radiation-free option we have.
And are there any specific worries about gestational age?
That's a great question. The sources say MRI is safe at any gestational age, even up to a 3.0 Tesla magnet. But, we're always extra cautious in the first trimester. The developing embryo might be a bit more sensitive to thermal effects.
So you might use a lower strength magnet.
We might prefer a 1.5 Tesla, yeah. But the general consensus is that the diagnostic benefit far outweighs that theoretical risk.
Okay, let's pivot to the other big issue. Contrast. We know CT contrast can be tough on the kidneys. How does MRI solve that problem?
It's invaluable there, especially for patients with really impaired kidneys, acute kidney injury, or severe chronic renal failure.
How severe are we talking?
We're talking an estimated GFR, that's the glomerular filtration rate below 15. For those patients, a non-contrast MRI gives us so much more information than a non-contrast CT.
The soft tissue resolution is just better.
Oh, vastly better. If you're looking for an abscess or pyelonephritis or a bleed, the MRI will show you the pathology and the surrounding tissues with incredible clarity.
But what about MRI's own contrast agents, the gadolinium-based ones, the GBCAs? Are they totally risk-free for those same kidney patients?
No, absolutely not. And this is probably one of the most critical safety conversations in radiology. We learned a long time ago that gadolinium can, in very rare cases, trigger a horrible condition called nephrogenic systemic fibrosis, or NSF, in patients with severe renal failure.
So you have to be incredibly careful.
Incredibly. We actually categorize the GBCAs into groups. Group I agents they're avoided completely in anyone with poor kidney function. The risk is too high.
So what do you use?
We only consider group 2 agents, which are things like EUAVIST. But even then, it's after a very careful risk-benefit discussion. And if a patient needs more than one dose, we try to space them out by at least 7 days.
And what if that patient is also pregnant?
That is the diagnostic double whammy. GBCAs are generally not recommended in pregnancy, period. They're FDA Class C.
Because they cross the placenta.
They cross the placenta, and we just don't have enough data on the effects. So it has to be a true life-or-death situation where the benefit clearly outweighs the potential risk. It is always the last resort.
Okay, so the patient is cleared, the decision is made. Let's get into the interpretation.
Yeah.
The actual language of emergency MRI. To really get it, you have to know what the radiologist is seeing.
Yeah.
So you break down the key sequences for us.
Absolutely. Let's start with the two big ones, T1 weighted and T2 weighted. Think of them as just different ways of looking at the body's tissues.
Okay.
T2 weighted, or T2W, is your fluid finder.
The fluid finder, I like that.
Yeah, anything with a lot of water, content bile, fluid in an abscess, edema, swelling, it all shows up as bright, or hyperintense as we call it. And in an emergency, we use fast versions like fast spin echo or FSE. And even faster is single shot fast spin echo, SSFSE.
That's the one you use when the patient can't hold their breath.
That's the one. It grabs that anatomical and fluid information almost instantly. It's a lifesaver.
So T2 finds the fluid, the plumbing problems. What does T1 weighted show you?
T1W gives you the best, crispest anatomy. And while T2 makes fluid bright, T1 makes other things bright. Fat is T1 bright. Bile can be T1 bright. And really critically in an emergency, subacute hemorrhage is T1 bright.
So blood, that's a day or two old.
Exactly. It stands out really clearly against the other tissues. We also use T1 to play a little detection game with fat, using what we call in-phase and out-of-phase images. If something has microscopic fat in it, its signal will literally drop on the out-of-phase image.
And that helps you identify what a mass is made of.
Right. And it's also how we see fat stranding, that sign of inflammation around something nasty, which can create these dark lines. We sometimes call it the Indie ink artifact.
That's a great visual. So what about just pure speed, the fastest, most motion-proof sequels you have?
That would be BSSFP, balanced, steady, state-free procession.
That's a mouthful.
It is, but think of it as our Swiss Army knife. It's fast, it's motion insensitive, it's great with fluid. We use it to quickly confirm small, dense things like an appendicolith.
A stone in the appendix.
Or stones in the kidneys or bile ducts. It's also great for a quick look at blood vessels to spot a clot, which would show up as a filling defect.
Okay, now let's get to the real smoking gun for acute disease, the diffusion restriction code. This is what really tells you if something is new and active, right?
It is the absolute heart of emergency MRI. We're talking about diffusion-weighted imaging, or DWI, paired with something called an apparent diffusion coefficient map, or ADC map. So the theory is when cells are acutely injured or infected or cancerous, they swell up, and that swelling restricts how water molecules can move around inside the tissue.
And you can see that restriction on the scan.
We can. It gives us a very specific signature, the code. The diseased area shows up bright on the DWI sequence, and this is the key part. It shows up dark on the ADC map. That DWI bright ADC dark signature is the calling card for an acute stroke, a fresh abscess, a dense tumor. It's unmistakable.
With all these different things, blood, fluid, fat, all looking bright on different sequences, how do you keep from getting fooled? What about this idea of pseudo-enhancement?
That's a huge pitfall, a critical one. Let's say you have a collection of old blood or really thick, sludgy bile.
Okay.
That stuff can be naturally bright on a T1 image even before you inject contrast. So when you do inject the contrast, it might look like it's enhancing.
But it's not. The brightness was already there.
Exactly. That's pseudo-enhancement.
Yeah.
So to solve that, we have to do some digital subtraction. We take the post-contrast image and we digitally subtract the pre-contrast image from it. If something really enhanced, if dye really flowed into it, it will stay bright on that subtracted image.
And if it was just intrinsically bright to begin with?
It'll turn dark. And that's how you prove it was pseudo-enhancement. It's vital for knowing the true extent of disease.
Okay, let's apply all this. Let's talk specific cases, starting with the liver and bile ducts, where things can get really complex.
For sure. In the hepatobiliary system, our main tool is MRCP, magnetic resonance cholangiopancreatography. What's cool about this is we don't even inject contrast to see the ducts. We use the bile itself.
How does that work?
Well, bile is mostly water, so it's naturally super bright on T2 weighted images. The bile ducts just light up like a Christmas tree. So if there's a stone, a calculus, it has no water in it. So it appears as a dark little shape, a hypointense filling defect inside that bright duct. It gives us an amazing non-invasive map of the whole system.
What about a surgical emergency, like a bile leak after someone's had part of their liver removed?
That needs a more advanced trick. We use a special contrast agent called gadoxetate or eovist. It's unique because healthy liver cells actually pull it out of the blood and then secrete it directly into the bile. It basically turns the contrast into a tracer.
So you can watch it flow through the system.
Precisely. If there's a leak, you'll see the contrast agent, the extravasation spilling out of the bile duct and into a collection. Usually you see that on the 20-minute delayed images. For a really slow leak, you might have to wait even longer, maybe 60 or 90 minutes to be sure.
Another really nasty one is acute pancreatitis. Figuring out how much of the pancreas has died, the necrosis, is critical. How does MRI help there?
It's excellent for grading necrosis and checking for hemorrhage, but there's a huge trap here. Hemorrhage in the pancreas often looks bright on T1 images. So if the whole gland is hemorrhagic, it can actually look deceptively normal on the pre-contrast scan.
It mimics a healthy pancreas.
It can, yeah. So you absolutely cannot trust that pre-contrast image. You have to look at the post-contrast T1s. The true sign of necrosis is a lack of enhancement. And if part of the gland doesn't light up after the dye goes in, that tissue is dead.
Got it. Okay, let's move to two areas where MRI is the undisputed champion, pregnancy and certain pelvic diseases.
Right. For pregnancy, its radiation-free nature is everything. Acute appendicitis is a classic example. The appendix moves as the uterus grows, often way up above the hip bone.
Making it impossible to see on ultrasound.
Often, yes. But MRI still has incredible sensitivity and specificity for finding that inflamed appendix, something like 94 and 97%. It's also essential for obstetric emergencies, like an abruptio placenta, a placental abruption.
Hemorrhage.
A hemorrhage, exactly. And here, the T1 sequence is king. It's so much better at showing you the blood products, the hematoma, than T2 is. T2 often underestimates how bad the bleed really is.
And finally, what about perianal disease? Fistulas and abscesses. That requires some really precise mapping.
It does. For that, usually in patients with Crohn's disease, a small field of view MRI of the pelvis is the gold standard. The whole mission is to map the tract. We use T2 sequences to follow its path, and if there's an active abscess, it has that classic signature we talked about.
Let me guess. It's bright on DWI and dark on ADC.
You got it. Central diffusion restriction. And after contrast, it'll have a bright enhancing rim. The final report is all about communicating that map to the surgeon. We use something called the part classification to describe exactly where the fistula is in relation to the sphincter muscles.
So the surgeon knows exactly what they're getting into.
Exactly. We document everything, the main track, any abscesses, any side branches. It's a surgical roadmap.
This has been a fantastic guide through some very high-pressure medicine. So to wrap this up for the learner, what's the big takeaway? Emergency body MRI isn't just one machine. It's really this whole suite of targeted techniques, T1, T2, DWI, special contrast, all designed to answer very specific, urgent questions.
That's it, exactly. It's a strategy. And if you think about the things we see on co-infection, malignancy, trauma, they all force that trade-off between speed and precision. Using a non-contrast study or protocol with fewer sequences, that's the high-stakes compromise you have to make for the sake of speed and patient safety.
We've just gone through all the physics and protocols radiologists use when time is literally measured in minutes. When you really look at all of this, what stands out to me is how much life-saving information rests on finding just a few seconds of usable data, sometimes without the full protocol, sometimes without any contrast at all. It's really pushing the limits of expertise under the most extreme pressure, something to think about.